Hello, class. Today we're going to be discussing a topic related to labor and delivery complication, shoulder dystocia. A shoulder dystocia is an obstetrical emergency and is one of the most frightening emergencies in the delivery room. About 1 in every 200 births experience a shoulder dystocia. Most cases occur without warning, and it's important that if a shoulder dystocia were to occur, that medical professionals remain calm so that their management of this emergency is effective and that they can provide the specific interventions and maneuvers safely so that there is a successful delivery of a healthy infant. So what exactly is a shoulder dystocia? It happens when one or both of the baby's shoulders get stuck inside the mother's pelvis during childbirth. It's diagnosed when the body fails to deliver within 1 minute of delivering the baby's head. When a dystocia occurs, the infant's head will emerge, but then it will retract against the perineum. The infant will appear squished in the face, become red, and really puffy. This is called the turtle sign, and this is a clear indicator of a positive shoulder dystocia. The turtle sign much like resembles what an actual turtle looks like when it recoils back into its shell. There are a few risk factors associated with having a higher risk of having a shoulder dystocia. Age, for one, if you're older than 35, if you have a short stature, if your pelvis is small or abnormal, if your baby is greater than 42 weeks gestational age, if your baby has been estimated at greater than 4,500 grams, if you have diabetes, because diabetes puts you at risk for having a higher chance of a giant baby, especially if the diabetes has been uncontrolled throughout the pregnancy, if you had an operative vaginal delivery, if you came in to be induced rather than you went into labor on your own, if you had a prolonged first or second stage of labor. The turtle sign. Lots of times medical professionals don't know that you're going to have a shoulder, and then the baby's head comes and he presents with the turtle sign, and then the protocol begins and has been activated to prepare for a shoulder. If you need instrumental delivery, if you need a pop-off, a kiwi, or forceps delivery, that puts you at greater risk. And if you have a shoulder dystocia, moms who've had a shoulder dystocia in the past are at a 10% increase for having a shoulder again. And if the shoulder doesn't rotate or descend down, that is also a clear indicator that mom is going to have a shoulder dystocia. These are forceps here. They wrap around the baby's head and help guide the baby's head out. And then this is what a baby that is bigger than the average size. There are maternal complications for moms that are having suffering from a shoulder dystocia. Postpartum hemorrhage is a big one. Perineal lacerations that extend into the anal sphincter. So over here I've included a third-degree laceration, and as you can see, it goes into the sphincter. It's torn a little bit. Now a fourth degree would be torn a little bit more in here. A lot of times third and fourth degree lacerations require surgical intervention, and we'll have moms go back for surgery after they've delivered the baby because it's such a big repair and can be very painful. If mom has had a symphyseal separation, neuropathy of lateral femoral cutaneous nerve, and that's because the maneuvers and positions that we do could damage her nerve. And also a uterine rupture. So uterine rupture is a big emergency as well. And here I've enclosed a picture, and this is what a uterine rupture would appear as though. A lot of times moms become pretty critical during a uterine rupture, and it becomes an emergent situation where mom is getting taken back for a C-section. And lots of times those babies wind up in the NICU. There are neonatal complications as well, such as the Klumpke paralysis, Erb's palsy, cerebral palsy, brachial plexus palsy, getting a fractured clavicle and humerus, and in severe cases, hypoxic injury and death. However, I want to touch on the brachial plexus palsy. A lot of times within 6 to 12 months, those will resolve. And this is a picture demonstrating how an arm would look after a shoulder if the baby had been diagnosed with Erb's palsy. And then this is a baby who underwent a hypoxic injury from having a shoulder dystocia. So the baby's intubated and hooked up to all sorts of monitors. Usually after the babies have experienced a hypoxic injury and they come to the NICU, they'll be placed on a cooling blanket and will be cooled for 3 days. And then once they're rewarmed, an EKG and an EEG will be performed to determine their heart function and their brain activity to see if they've experienced some encephalopathy and what the plan of care would be after that. And then in some cases, death could occur after a shoulder dystocia. So there is management and there's ways that the team can prepare for a shoulder, especially if mom has a few of those risk factors. A lot of times the team will begin preparing the room, making sure it's clear of any clutter so that additional personnel and equipment can fit in the room. They want to make sure that they notify the NICU and any other key personnel like an anesthesiologist. And they want to make sure that all those individuals are there and ready just in case the shoulder dystocia doesn't go as planned and different interventions are required. The patient's bladder also needs to be emptied, which lots of times if parents have opted to receive an epidural, they'll have a Foley catheter in until it's time for delivery, so their bladders will be empty. Additionally, if it's anticipated that a shoulder dystocia is imminent, providers will continue delivering the fetal head until the shoulder is visible, and then with the momentum of the fetal head being delivering, they will just continue on delivering rather than stopping and suctioning the oropharynx. That way, it's just like one smooth motion, and then hopefully that will bypass a shoulder happening. There are reduction maneuvers. However, it's really important to be sure not to apply excessive force to the fetal head or neck. And you want to make sure that fundal pressure is avoided at all costs because these can hurt both mom and baby. So there's an acronym for a shoulder that we go by. It's called the HELPER acronym. And there's also reduction maneuvers. H stands for calling for help. And you're going to be activating the protocol that's been prearranged for shoulder dystocias. You're going to ensure appropriate personnel respond with the appropriate equipment. We want to make sure we give the NICU a heads up prior to mom crowning so that they can be at the bedside in a timely fashion so that we can perform interventions and maneuvers in a timely fashion so that the delivery of the infant is safe. E stands for evaluating for the episiotomy. This is necessary if more room is needed to do the rotation maneuvers. But because a shoulder dystocia is a bony impaction, an episiotomy alone will not release the shoulder. So it's very important to remember that an episiotomy will not relieve the shoulder, but it will help so that the team has room in the canal to turn the baby and get more instruments in if needed, or a hand in if needed, or deliver that arm if needed. L stands for legs. Basically, you want to perform what's called the McRoberts maneuver, and that means that mom's legs will be flexed and abducted up to her hips, and we want to position her thighs up onto her abdomen. It sounds like it's not a doable thing, but believe me, it is doable. It helps to flatten the sacral promontory and results in the cephalad rotation of the pubic symphysis. A lot of times, nurses and family members, if they're present at the bedside during delivery, can help provide the assistance for this maneuver. We want to make sure the biggest thing is we're widening the pelvis and we're flattening that spine of the lower back. And then if that positioning doesn't work, then we'll go to P, which is suprapubic pressure. So while mom's in the McRoberts maneuver, a medical professional, specifically a doc or a nurse, will put pressure on the lower abdomen, and it's on the suprapubic over the fetal anterior shoulder. And you want to put pressure like where you're doing CPR, with a downward and lateral motion on the posterior aspect of the fetal shoulder. And this maneuver must be attempted while continuing downward traction. And sometimes you might go back and forth putting that pressure. E stands for enter maneuvers or internal rotations. These maneuvers attempt to manipulate the fetus to rotate that shoulder so that it can go under the maternal symphysis, which can be very difficult to perform when the anterior shoulder is wedged. So sometimes it's necessary to push the fetus back up into the pelvis in order to accomplish these maneuvers. R stands for removing the posterior arm. It's also called the Jacquemere's maneuver, where the posterior arm from the birth canal is shortened and it allows the fetus to drop into the sacral hollow, which frees the impaction. So the elbow gets flexed and the forearm is delivered in a sweeping motion. And it's very important to not grasp or pull directly on the arm because it could fracture the humerus. And then another intervention is rolling the patient. That's also called the Gaskin maneuver. And when you roll the patient, you want to get them off their back onto all fours. And a lot of times staff thinks this is something that can't be done because parents opt for epidurals, but this can be done and it's quite doable, and it's usually a team effort and pretty quickly done. The patient gets on all fours, and usually what happens is during the turning, the shoulder will dislodge, and then once the position change has been completed, basically gravity helps in the disimpaction of the fetal shoulders. So I did talk about the McRoberts maneuver. You're putting the thighs up on the abdomen, and this picture demonstrates what it would look like. They're pushed back even further. This is kind of being a kind picture. And this arm here is performing the suprapubic pressure. And this is demonstrating what a Gaskin maneuver looks like. And the biggest thing here is you want to make sure the back is arched, because this helps to widen the pelvic outlet. And then there are last resort maneuvers or interventions that sometimes we just have to perform at a last-ditch effort. So obviously we wouldn't want to deliberately clavicle fracture for a baby, but this will help reduce the diameter of the shoulder so that it can pass through the birth canal. And usually the provider just puts direct upward pressure on the mid portion of the fetal clavicle, which helps to reduce the shoulder to shoulder distance. And then the Zavanelli maneuver is when they know that they're going to have to go back for a section. There's no way this baby's fitting. However, this baby's head already has been out, so the doctor has to push the baby's head back up into the birth canal and puts pressure so that the baby's head stays up and continues holding upward pressure until the cesarean delivery is accomplished. And then the maternal symphysotomy, which is breaking the pubic bone. An abdominal rescue, which is a hysterotomy, which facilitates vaginal delivery of the impacted shoulder. And then general anesthesia. A lot of times parents are tense, moms specifically, because they're laboring, are tense and their contractions are just constantly one after another. So this might bring uterine relaxation to the affected delivery. And then here I've enclosed a picture of a broken clavicle. As you can see, it's fractured right here. And a lot of times these babies will go over to the NICU briefly, and then they end up going home just fine if that's all their issue has been. So thank you for listening. I hope you learned about a labor and delivery complication specifically related to shoulder dystocia.